stronger. Thank you all for joining us after our long summer break. Hope you all enjoyed the break and the time off and all the activities that we undertake in this wonderful summer season, including the sweating. But we're going to get the meeting started with our opening prayer. So if we can all bow our heads and close our eyes for the prayer. Almighty and loving Father, creator of heaven and earth, we praise you and we adore you. We humbly ask your forgiveness for our sins. We are gathered here today for our meeting, and we ask that you send your Holy Spirit to be our guide and give us the wisdom to understand the topic that we're going to discuss. Enlighten our minds and let your love be upon us, and may this meeting bring success, growth, and knowledge to all who are joined in with us. We thank you, Father, for this precious time that you have given us.
Recording in progress.
We pray through our Lord Jesus Christ, your Son, who lives and reigns with you in the unity of the Holy Spirit, one God forever and ever. Amen. So thank you all once again for joining us. And we've had, 2 months break? 3 months break, I think, huh? It's good to be back. Did anyone have any birthdays, anniversaries, any celebrations they'd like to share with the group before we get started? Feel free to open your mics and let us know if you have any events you're celebrating. Or you can put it in the chat. Nobody's celebrating? Okay, maybe the latecomers. Okay, so we will now move on to Erin, who will share some announcements of upcoming events. Please, Erin.
Myself.
I was just going to say, Erin, if you're on, you're muted.
Yeah, sorry. All right. This month, it's thyroid cancer. I know it's a rare cancer, but it's the awareness is also in September, along with prostate and childhood cancer. And we've had a few persons that come to the Cancer Society for assistance because being diagnosed with thyroid cancer. Okay, let's actually start the video. Okay. Sorry about that. So yes, we're highlighting thyroid cancer for this month. And we have, later on, we will have Dr. Siraj come and present. Now, as for Prostate Cancer Month, we are having a island-wide prostate screening in most of the family islands that we have branches. So we have in Lower Bow, Gregory Town, Hatchet Bay, Palmetto Point, Rock Sound, Windsor's Bay, Nicholstown, North Andros, Kemps Bay, South Andros, Mangrove Key, South Andros, Fresh Creek, Central Andros, Deadman's Key, and Sims, Long Island. We have a PSA screening in San Salvador, but they haven't given us the date. So hopefully soon. So please encourage your family members that are on those islands to go out to those clinic on the date and just do the blood test. It's no other screening or examination. It will only taking a little bit of blood to test your PSA level. So men, please don't be afraid to go out and get your PSA tested. We're also having a free clinic on the island of Cat Island, where they will be doing not only PSA testing for men, but pap smear for women. Every month we go to a different island and have these free clinics, and we encourage persons on the islands, persons who are in Nassau but know a family on that island. Please encourage them to come and get tested. It's free of charge. All they have to do is just show up during the time of 9 a.m. to 2 p.m. and they will be screened. The results, the test samples go to a private lab, and then they will get back their results. Okay, so please encourage your family members, your friends, your neighbors, anyone to go out and take advantage of these free screenings. The diocesan chorale is having a concert under the patronage of our president, Miss Rochelle Wilkinson, under the theme, I Believe. We are selling tickets at the Cancer Society, and the part proceeds will assist persons at our Cancer Caring Center. So please come and enjoy the chorale and the singing, and be a believer and show your support. So if you want to reserve your ticket, just call the office at 323-4441 or 323-4482 and get your tickets. Tickets are on sale any day because we have somebody there 24/7. So you can go even on the weekend and pick up your tickets. So please support this event. Like I mentioned earlier, September is also Childhood Cancer Month. So we will have Dr. Sinki speak on childhood cancer, and we're hoping to get the kids that we sent off to Camp Good Days to be on the call to tell their experience of being at a camp in Rochester, New York, along with other persons internationally, kids who have been diagnosed with cancer. And I know they had a wonderful time. So tune in, and you can have your kids tune into this too. It's going to be a short presentation. Our Long Island branch is having their annual Ball of Hope. It's on the 28th. So if you, again, persons in the Long Island community, or if you're visiting that island, I know we had a couple that visited last year from Nassau, and they attended the ball because it was during their visit there. So if you're visiting and you want to go and enjoy and also support, we are so grateful for you doing that. St. Jude's, again, this is another organization that partnered with the Cancer Society and St. Jude. The funds from this walk help our Freedom Kids. And the Freedom Kids are children aged 2 to 17 years that have been diagnosed with cancer. And so we have a special support group for them. We give them 4 events during the year. We start off with an Easter egg, then we have a back to school, then we have a summer bash, back to school, and then we climax the year with a Christmas party. So come on, register and be a part and assist a child diagnosed with cancer and join the fun. Next month is Breast Cancer Awareness Month, and we have our breast cancer awareness shirts already in stock. These are the shirts that are for this year. It's just t-shirts, dry fit t-shirts. We do have some polo shirts that we have from our last year. But come on now, the shirts are available. You don't have to wait until October. We have them in stock right now, so you can get them early and make sure get your sizes. This is the pink, and then we have the white in the dry fit tees. These are our last year shirts, and we have them on sale. They're $30 for the black and pink and black, and the white and pink and the pink and white. And then the other ones we have for $25, all sizes from small to 3X. They're all the same price. Like I said, we have the pink and black, and they're unisex. And then we have the black and pink. So if you see any that you like, just drop on in at the Cancer Society and get your shirts. And I thank you so much for that presentation. That's all for the announcement for today, and we will turn it over back to our moderator, Madam President.
Thank you, Erin. Thank you so much. Lots of good announcements there. Just before you started, we did have somebody in the chat, Burton Lockhart, is celebrating or has celebrated a 28th wedding anniversary on July 6th. 28 years. That's awesome. Congratulations. I hope that you celebrated in grand style. I hope you're still celebrating, actually. Anyone else, feel free to put it in the chat and we'll make the announcements before we close out. But for now, we will introduce our speaker, Dr. Sybil Suraj. She hails from the beautiful island of St. Lucia. She's a consultant ENT surgeon at Princess Margaret Hospital and the director of ENT Solutions Limited, Palmdale, Nassau. She completed her undergrad studies in medicine in 2004 at UWI St. Augustine campus. She moved on to pursue postgrad studies in ENT at UWI Mona campus in Jamaica. And she completed the same in 2017. As a part of her training, she did an externship in the UK and Europe, whereby she attended several courses in head and neck surgery, endoscopic sinus, skull-based air, and robotic surgery. She's also attended courses in the US, including Johns Hopkins University Hospital, and most recently this year at the University of Pittsburgh. ENT surgery is indeed her passion, and she loves meeting people, and her profession allows her to meet and treat both children and adults, male and female. And she says that personally, it's exceptionally rewarding to be able to improve the quality of life of her patients. And that's what motivates her to continue striving to be better in her profession. Aside from work, she absolutely loves the outdoors, particularly enjoys the beach and the ocean, especially in our beautiful waters in the Bahamas, swimming, jogging and exercising, fishing and traveling. So without further delay, I will turn it over to Dr. Sybil Suraj, and I'm sure we are all excited to hear what she has to say this evening.
Good evening. Thank you, Ms. Wilkinson, for your introduction. Thank you to the rest of the team of the Cancer Society of the Bahamas for inviting me here to do the talk on thyroid cancer. A very relevant, although rare, but a very relevant topic, and I hope to educate people in this chat today. I thank the audience for being here as well. It wouldn't be possible without them. You know, I'm sure they had more exciting things to do, but they're here with us this evening. Let me try share my screen now. Should be here. Okay. I need to try close this window.
We could see your
Right.
presentation.
To close this here. So I can see my entire screen. Alrighty. Good. So I'm going to talk about quite a few things this evening. And here's an overview of what I'll be speaking on tonight. I'll be looking at the development of the thyroid gland, starting from the fetal stage in the womb, talking about the anatomy of the thyroid gland, looking at the exact location of the gland. We'll be talking about the numerous functions of the thyroid gland, numerous but very essential. Be talking about thyroid cancer, the different types of thyroid cancer, the incidence of thyroid cancer, as well as the symptoms, how patients can present with their thyroid cancer. We're going to be discussing as well evaluation of patients with thyroid cancer, how we're going to assess these patients, what investigations or tests are usually requested in patients we suspect of thyroid cancer. And we're also going to discuss the definitive treatment of thyroid cancer, which usually involves surgery and radioactive iodine. Right, here we go. We also we will also be talking about the new treatment modalities for advanced thyroid cancer, namely targeted therapy. And I will touch on thyroid cancer in pregnancy. Okay. All right, so the thyroid gland, right, it's a butterfly-shaped gland located in the front of the neck. Well, we say the anterior neck, but the front of the neck. And it's the first endocrine gland. There are others, but it is the first gland to develop. It starts developing around the 24th day in the fetal stage in the womb. And it starts from a small bud or diverticulum, which is located in the base of the tongue. And it gradually descends into the neck and assumes its normal position by the 7th week of fetal life in the womb. It lies just below the voice box or the Adam's apple, that's as you would maybe know it, and behind the muscles of the neck, namely the sternocleidomastoid muscles and the sternohyoid muscles. And it straddles or sits over the trachea, the windpipe, the tracheal rings 2 to 4. It's only about 2 inches in length and weighs about 24 grams and not usually visible when it's of a normal size. When looking at someone, you can't see it unless it's enlarged. So this picture shows the, my mouse, where's my mouse? Right here. This picture shows the development of the thyroid gland in the fetal stage, fetal life. And it starts, this is the tooth here, this is the tongue, the back of the tongue, where, like I said, a small bud or diverticulum develops here and grows and descends down gradually into the neck. That starts from day 24. And by week 7, the thyroid gland assumes its normal position here. Now, this duct, this duct usually obliterates or seals off by week 10. In some people, it may persist, but most people it obliterates. We won't talk about those that remain. That's another subject. And this is just the gross look of the thyroid gland. You can see that, like I said, it's shaped like a butterfly. We have the right lobe and the left lobe, and it joins in the middle. This is the isthmus. It sits right over the windpipe or the trachea, just below the thyroid cartilage or the Adam's apple. So you can see how in close proximity the thyroid gland is to the windpipe. Or the trachea. It has a very rich blood supply supplied by the superior thyroid artery and the inferior thyroid artery. And this rich supply enables it to perform its numerous but essential functions. And so what are the functions of the thyroid? Let me talk about that. It is the largest endocrine gland. When I say endocrine gland, I mean by that I mean it produces and its hormones into the bloodstream, carried everywhere in the body, really. All cells require thyroid hormones for normal function. So it's quite important. And the hormones produce thyroxine, T4, T3, and calcitonin. And as I said earlier, they're very important, but very important metabolic rate of metabolism and production of energy, and which every cell requires. So very, very important structure. And it has effects on all the major systems in the body. The heart or cardiovascular system, where it increases heart rate and the force of contraction of the heart. And that's why patients who have a hyperactive or overactive thyroid gland, they'll complain of increased or rapid heart rate. Also, it influences development of the brain as well as intellect from fetal stage in the womb. It's also necessary for the gastrointestinal tract, where it increases appetite, etc. It helps in the production of hemoglobin. It helps with metabolic rate, whereby it increases the oxygen consumption in most tissues and heat production. And again, that's why patients who have an overactive thyroid gland. They lose quite a bit of weight, and they sweat quite a bit. Their heart is racing, and they're usually heat intolerant. It affects the respiratory system. It influences lung development in the developing fetus, as well as the rate and depth of breathing or respiration. The skeletal system is also affected by it. It causes maturation of the skeletal system, as well as bone and teeth formation. The skin plays a role in the skin, whereby it assists with growth of the hair follicles. So numerous essential functions of the thyroid gland. So patients who present usually for thyroid swelling, and usually the thyroid swelling in the neck is usually one or multiple nodules or lumps in the gland. And by definition, this means it's an area of the gland that is distinctly different from the rest of the gland. And it could be seen distinctly different on ultrasound or CT or MRI of the neck when done. They are very common. These are thyroid nodules, very common. They usually goiters, and present in 70% of the population. So quite a lot of people have thyroid nodules, and they may be small, they're not all large. But if ultrasounds were to be done in the population, about 70% of people have them. Many are found incidentally, patients who have had a CT or MRI scan of the neck for other reasons, such as if they have neck pain, they may get an MRI of the spine of the neck, and incidentally, a thyroid swelling or nodule is seen. And these are called incidentalomas because they're seen incidentally. Thyroid nodules are more common in the age group 35 to 59 and mostly seen in women. We're going to talk about the different types of thyroid cancer. Although thyroid nodules or lumps are quite common, like I said, they're seen in 70% of the population, only about 15% actually have thyroid cancer, which is a good thing. It is one of the most common head and neck cancers, though. However, the most common head and neck cancers that we see are usually cancer of the squamous cell cancer of the throat, the voice box. These occur more commonly than thyroid cancers. Worldwide in 2020, it was found that the incidence of thyroid cancer was in women 10 to 100,000, and in men about 3 to 100,000 in men. So it's less in men than women. The mortality rate is low, less than 1 per 100,000. And there are different types of thyroid cancer, the most common being papillary thyroid cancer, and it's seen in 85% of the time. The next common is follicular thyroid cancer, seen in 12% of cases. We have other thyroid cancers, namely medullary thyroid cancer. You can get lymphomas of the thyroid gland. Anaplastic thyroid cancer, very rare, seen in less than 3% of cases. Very rare cancer, but very, very aggressive when diagnosed, with a very high death rate or mortality. Patients are usually deceased by 6 to 12 months. Fortunately, it occurs even more rarely. We can get secondary cancers, meaning cancers that have spread from elsewhere to the thyroid gland. It could spread from the breast, the prostate gland, and from the kidney or kidneys. And so what are the symptoms of thyroid cancer? What should alert a patient, to a cancerous process happening in the thyroid gland? So patients, for example, who've had a neck swelling or goiter for a while, and suddenly it starts increasing in size very rapidly, that would suggest a cancerous process. Cancers are usually painless until late. If the swelling is quite hard, rock hard and firm, it's not a good sign either. Patients who are hoarse would usually suggest cancer, because the cancer can invade the nerve that supplies your voice box, causing hoarseness. And so patients who are hoarse need to see their doctors quite, readily or early. as soon as that happens. Choking with meals, whether it be solids or liquids, patients always coughing when they eat or drink. That could be suggestive of a cancerous process. Patients who have dysphagia, that means difficulty swallowing your food or their food, could be a sign of cancer. The swallowing passage or esophagus is also very closely related to the thyroid gland. And so, cancer of the thyroid can extend into that area and cause difficulty swallowing. Patients who are coughing or spitting of blood, this can be a feature of cancer. Also, noisy breathing, called stridor, due to paralysis or lack of function, improper function of the vocal cords or the voice box, can cause difficulty breathing and usually indicative of a cancerous process happening. So thyroid masses can be quite impressive, as you can see here. They can get really large. Doesn't mean that there's cancer there. We won't know until we investigate these patients, but they can get pretty big. In surgery, sometimes the staff would say, "Doc, have we delivered the baby? Is it a boy or girl?" That's how big they can get. Now, obviously, we want patients to present to come to the doctor before it gets to that point. What are the factors suggesting that this may be thyroid cancer additionally? Extremes of age. So patients who are younger than 20 years, or older patients more than 60, they are at a higher risk of developing thyroid cancer. If patients have been previously exposed or had radiation to the head and neck for cancers that they had before, they have an increased risk of getting thyroid cancer of up to 40%. The male gender is at increased risk of thyroid cancer as opposed to females. Patients who have Hashimoto's thyroiditis. I know that's a lot to say, but it's really an autoimmune condition whereby the body cells fights the thyroid gland. They have a risk of developing lymphomas in the long run and should be observed closely. Patients who have long-standing goiters or long-standing thyroid swellings, these can change over time to malignancies. There can also be genetic mutations or abnormalities, which can cause or predispose to thyroid cancer. The RET mutation is one of them. It's the RET gene mutation. And when that happens, patients develop what we call MEN syndrome. It means multiple endocrine neoplasia, where multiple endocrine glands are affected, including the thyroid gland, which can develop medullary thyroid cancer, MTC. You can also get mutations or abnormality of the APC gene, and which causes FAP, which is familial adenomatous polyposis, which is characterized by several hundreds of polyps in the colon, which usually become malignant over time. This is also associated with thyroid cancer, that type being papillary thyroid cancer, or PTC. There are other genetic mutations, too numerous to mention. Let's say we just mentioned the more common ones. So how do we evaluate or assess a patient we suspect with thyroid cancer or has a thyroid swelling? First, you want to take a thorough history, have a good long chat with the patient, elicit how long they've had this neck swelling. Has it grown rapidly recently? Are there any associated signs or symptoms like hoarseness, the symptoms I mentioned earlier, choking with meals, spitting of blood? These questions will help you, clue into whether this is a malignant process or cancerous process happening. Have they been exposed to radiation in the past? Do they have a family history of thyroid cancer? All these questions have to be asked. Following the history, we take a physical examination. Full examination, the neck especially, you're going to examine the neck to see if this mass or swelling is hard, rock hard, is it fixed, it can't move? These are features of a malignant or cancerous process. Patients who are hoarse or patients who complain of spitting of blood or choking with meals, we definitely want to have a look at the voice box using a flexible scope. And it's a tiny camera that's passed through the nostril and down into the throat, and we can have a good look at the voice box to see if that is affected by the growth in the neck. And it's usually well tolerated and done in the office. Next, we want to order some blood tests, namely the thyroid stimulating hormone. This blood test is going to tell us whether the gland is overactive or underactive, or if it's normally functioning. We could order some additional tests like a complete blood count, kidney function tests, other tests, especially if we're planning for surgery. Next, we want to order a thyroid ultrasound, very important. Even patients who have come to the clinic with a CT scan or MRI of the neck showing a thyroid swelling, according to the American Thyroid Association, a thyroid ultrasound needs to be requested because we get so much more information from the ultrasound. Following which, you do a biopsy of the thyroid swelling. It's called a fine needle aspirate cytology, which I'll talk about some more. In patients with, we suspect advanced or late disease, we can order other scans like the CT scan and MRI to stage these patients and to see the exact extent of the cancer. And so on ultrasound, there are features that will be seen of the thyroid swellings or nodules. There are low-risk features, meaning low risk for cancer, and there are high-risk features, which suggest are highly suggestive of cancer. And the low-risk features are usually a nodular swelling that's hyperechoic or more fluid consistency. If there are coarse or big, thick calcifications, if there's increased blood supply around the nodule, if it's cystic, 99% of cysts are not cancerous. So that usually so that's a low risk for cancer as well. If it's spongiform or spongy, then that's a low risk for cancer on ultrasound. The high-risk features include microcalcifications, so fine calcifications, a lesion that's hypoechoic, meaning more solid. That's a high risk finding. A lesion or swelling that has increased blood supply centrally or in the middle is a high risk feature. Also, a nodule that has margins that are not smooth, they're irregular and jagged. That is a high risk feature. Nodules that are taller or longer than wide is also a high risk feature of malignancy or cancer in the thyroid nodule. And this diagram shows what I explained a while ago, whereby the low risk feature of a cyst here, it's the risk of cancer in a cyst is less than 1%, but as we go up, the risk of cancer increases in patients who have microcalcifications. This is what microcalcifications resemble or look like. A solid lesion versus a cystic lesion, a lesion that has irregular margins like this, as opposed to a smooth, lesion. And so these features are usually highly suggestive or suspicious for cancer, up to 90%. And so the ultrasound is very useful in assessing patients with thyroid swellings. Next, once you've done the ultrasound, we'd proceed to doing the fine needle aspirate cytology or biopsy. And it is the most accurate and cost-effective or cheap method of evaluating or assessing a thyroid nodule. It's very sensitive and specific, especially for thyroid cancer. It's minimally invasive, meaning it's usually requires just 1 or 2 sticks in the neck, and very well tolerated in the office. And sometimes we do it under local anesthesia, so a little numbing agent. When done with the ultrasound or under ultrasound guidance, the FNA is even more accurate, especially for smaller nodules that we cannot feel with our bare fingers. And so this is what the fine needle aspirate cytology looks like, the procedure. The patient is either sitting or lying down, and in a swelling that can be clearly seen, and you see that it's stabilized, the physician stabilizes the nodule with the fingers, and the needle with a syringe is used to aspirate some cells from the nodule, and these are put onto a slide, and a fixative is put onto it, and we send to the lab. So they could read and see if there's any suspicious cells there. Or it can be done with the ultrasound, where on the ultrasound guidance, the ultrasound shows exactly where to put that needle. And so the accuracy is better, especially for smaller nodules. And so what are the possibilities of your needle biopsy or cytology, if any? There are 6 possibilities. One, according to the Bethesda system by the American Thyroid Association guidelines, it could be non-diagnostic or maybe inadequate, because you do need a certain number of follicles to make a diagnosis. But in these cases, the risk of cancer is only up to 4%. We may opt to repeat the FNA in that case. It could be benign or not cancerous. And once the result comes back as benign, usually the risk of cancer being there is 3%, so it's quite low. So you usually can rest assured that this is not cancer. Or you can have an atypical abnormal result of follicular neoplasm, which portends a higher risk of cancer, 15 and 30% respectively. And in these situations, you may definitely want to repeat it, or do further testing on them, like genetic testing, to get some more information from that. If your result comes back as suspicious for cancer or malignancy, then the risk of cancer is as high as 75%. So you really can't ignore these patients. You have to do something further. And if it comes back as malignant or cancer, it usually is 99% correct. That is a cancerous lesion. And so how do we treat thyroid cancer? The treatment depends on the stage of the thyroid cancer. You know, if it's when you confine to the gland, then surgery is more limited, as opposed to if it's a spread to adjacent structures like the trachea or the esophagus, then surgery is more extensive. Treatment is more extensive. And it's usually done by a MDT approach, meaning a multidisciplinary team approach. It's a team approach involving the ENT surgeon, the endocrinologist, will help us with the thyroid hormone levels after surgery, and also calcium levels if the calcium levels drop after surgery. Also the anesthetist, you know, we may have a challenge putting that patient to sleep, especially with a large thyroid mass. Also the pathologist who reads the results, and the oncologist or the cancer doctor. So it's a team approach. Fortunately, most thyroid cancers are well differentiated, meaning they behave in a very orderly way. They resemble normal tissue, actually. And because of that, they have an excellent prognosis of very good 10-year survival. And that's a good thing. Most cancers, thyroid cancers are like that. However, anaplastic thyroid cancer, it's not like that. It's, like we said, it occurs very rarely, less than 3%, but has a very high mortality. Patients usually, you know, like I said, deceased within 6 to 12 months. And it's a poorly differentiated cancer as opposed to the well-differentiated cancers. And so the treatment is usually thyroid surgery or total thyroidectomy, removing the entire thyroid gland, as well as radioactive iodine after surgery. It can also involve a neck dissection, whereby if nodes or lymph nodes are involved, we can remove the lymph nodes. And this is called a neck dissection as well. It can involve a tracheostomy, meaning a tube being put into the trachea in the neck to allow breathing, especially patients who have a very large thyroid cancer, that can't be removed or excised. And we have to put an airway for them to breathe, excuse me, as it's obstructing or blocking the breathing or airway. Patients may need a feeding or tube or gastrostomy if they can't swallow. And these are patients usually with advanced thyroid cancer. There's targeted therapy, which we will talk more about, which is now evolving and very promising results. To date, there's no role for chemotherapy for differentiated thyroid cancers. So usually we don't use chemotherapy for these cancers. They don't respond. And so we don't use it. And so, like I said, treatment depends on the stage of the thyroid cancer. The age of the patient is the most important factor in prognosis or survival with thyroid cancer. Patients who are less than 45, they usually have a stage of up to stage 2, even though it has spread elsewhere, whereas patients who are more than 45 can get up to stage 4. So age is a very, very important factor when looking at the life expectancy for thyroid cancer. And how does thyroid cancer spread? Well, it can spread locally, meaning in the neck. It can spread to adjacent structures, which I mentioned earlier, like the esophagus or the swallowing passage, or the trachea or windpipe. It can extend to major blood vessels in the neck, like the carotid artery can encase it. Also invading, nerves, important nerves in the neck, like the nerve supplying the voice box, the recurrent laryngeal nerve, causing hoarseness and difficulty breathing if both are involved. It can spread to the lymph nodes. It can also spread, distant via the bloodstream to the lungs, the liver, bone, and brain. And so this is what a tracheostomy is, which I mentioned earlier. It's really a surgical airway, meaning an airway that is created by making a cut or incision in the neck, the front of the neck, making a window in the windpipe or trachea and putting this tube in so the patient can breathe in. And that usually is required when a hair is obstructed or blocked, whether it's by a large thyroid cancer or where the voice box stops working because of invasion of the nose to the voice box, and they need a method to breathe. So this is a tracheostomy, and this is how it looks. Obviously, it will affect speech. So the patient usually don't have a voice after, unless they have a speech valve put in. Patients are also limited to certain activities, like they can't swim. Otherwise, water can get right into that tube and can cause drowning. So all surgery has potential complications, and the same for thyroid surgery. And patients need to be fully aware of these complications before we, embark on surgery or consent for surgery. The possible complications of thyroid surgery are: 1, hoarseness. The recurrent laryngeal nerve lies very close to the thyroid gland and can be injured during surgery, especially in thyroid cancer. Usually it's temporary, and patient's voice usually returns back to normal after a few weeks once there's no permanent injury to the nerve. The patients can develop hypocalcemia or a drop in the blood calcium levels due to injury of the glands that regulate calcium levels in the blood. They're called the parathyroid glands, and they're very close to the thyroid glands. Again, usually transient or temporary. And that's where endocrinologists can help us bring back these calcium levels to normal. Tracheostomy could maybe needed if there's bilateral nerve injury, but that's very rare. Complications, I have to say, are few and far between, especially in experienced hands. You can get bleeding, but usually controlled, and there's always a risk of wound infection with any surgery. But again, usually not the case. So following surgery, these patients, they're referred for radioactive iodine, which is a form of radiation. And what that does is it kills or destroys or ablates any residual thyroid tissue after surgery, or thyroid disease that has spread elsewhere. The radioactive iodine will usually destroys these cells or tissue. It's usually given 3 to 6 weeks after surgery. Prior to radioactive iodine, though, patients are asked to stop Synthroid. So once a thyroidectomy or the total gland has been removed, patients are required to take the thyroxine or the hormones orally, because it is, like I said earlier, it is very important for your everyday function. And so, however, prior to radioactive iodine, we stop the thyroxine about 3 to 4 weeks before, so that if there's any residual thyroid tissue remaining, they can absorb or sort of soak up the radiation, and that helps. The radioactive iodine is usually taken as a pill or liquid, and it's absorbed by the thyroid tissue. Once patients have had radioactive iodine, they're advised to avoid human interaction for about 5 days after treatment. And once complete, because you could spread radiation to other people. Once completed, a whole body scan is usually advised to see if there's any more cancer left. And radioactive iodine has been found to reduce the risk of recurrent cancer or the cancer coming back. What are the side effects of radioactive iodine? Usually it's very well tolerated, few side effects. However, some patients experience some mild tenderness of the neck and swelling. They may experience dry mouth, gastric irritation, dry eyes. And these are usually self-limiting or reversible transient. You can get secondary cancers very rarely, namely leukemia, breast, bone, and lung cancer from radioactive iodine. And what is the long-term follow-up of patients with thyroid cancer, or how do we monitor them? Surveillance, what do we do for these patients? Well, we want to give them a slightly higher dose of the thyroxine hormone compared to patients who don't have cancer. And that is to reduce the if there's any residual thyroid tissue, to reduce the risk of it growing back. So it's called thyroid suppression. We also want to repeat thyroglobulin, which is also produced by the thyroid gland after 6 months. Rising levels of thyroglobulin will suggest that there's recurrent cancer. And so we need to monitor that. It's a tumor marker. We also want to do thyroglobulin antibodies, because antibodies present can give a falsely low thyroglobulin. And so we need to look out for that. I'll speak briefly on thyroid nodules in pregnancy, because you can get thyroid nodules in pregnancy and also cancers in pregnancy. And these patients are evaluated or assessed similarly as other patients. A neck ultrasound done, the fine needle aspirate cytology is done. Patients with papillary thyroid cancer, which I said is the most common thyroid cancer, patients with that cancer in early pregnancy can be monitored by ultrasound. And if there is no significant increase in size before 20 weeks, or 26 weeks of pregnancy, then if there's significant growth, then you consider surgery during pregnancy. However, if there is no significant growth and it's stable disease, surgery is usually planned for after delivery. And once the surgery is done, patients again get radioactive iodine, but breastfeeding would have to be withheld, as the baby can be exposed to radiation. So what is targeted therapy? Targeted therapy is usually for advanced thyroid cancers. Thankfully, advanced thyroid cancers, like I said, are rare, but this is the evolving and promising treatment of these cancers, targeted therapy. There's also there's stereotactic radiation, whereby it's radiation specifically to the thyroid tissue. There's also thermal destruction or ablation. Targeted therapy is based on the genetic mutations or alterations, which I mentioned earlier, which are seen very commonly in advanced thyroid cancer. It's seen in more than 50% of advanced thyroid cancers. And the genetic mutations are seen in the RAS gene, the BRAF gene, and the RET gene. So these are the most common genes that are mutated in advanced thyroid cancer. And so the targeted therapy targets these genetic abnormalities and have shown quite promising results. And so, like I said below, genetic alterations are targetable. Thankfully, thyroid cancer has the second highest rate of druggable targets. And I'll show you the chart to demonstrate that. It's highly promising for patients who have gotten radioactive iodine but not responded well to it or resistant to it. And usually there is a systemic therapy whereby it's taken as a pill, and it works through the entire system. And they're usually kinase inhibitors. So this chart shows how thyroid cancer is the second highest targetable cancer, next just below gastrointestinal stromal tumors, and that's good, and it shows very promising results for patients with advanced thyroid cancer, where the cancer can be treated with these drugs. And so different drugs show different benefit for different types of thyroid cancer based on the genetic alteration or mutation that is present. For example, lenvatinib is the first-line drug for undifferentiated thyroid cancer, and a 65% response rate was seen by Budesi et al. In 2022. Dobrofanib, is a second-line drug. Also, for medullary thyroid cancers with the RET mutation, other drugs recommended, RET inhibitors, namely. So historically, anaplastic thyroid cancer, or ATC, like I said, has a very high mortality or high death rate. And we said it's rare, which is good. Targeted treatment, however, has shown a dramatic and rapid responses of up to 80% in these patients, so quite dramatic. It's converted patients who have cancers that are unresectable or cannot be excised into resectable cancer, or cancers that can now be removed by surgery. And so with decreased surgical morbidity or adverse effects, because less surgery is done to adjacent structures. The long-term survival has increased with targeted therapy in these patients, and up to 80% patients now survive after 2 years. Now it's evolving, so we don't have long-term studies as yet to show further than that. And this was demonstrated by Wang et al. In the study Impact of Somatic Mutations on Survival Outcomes in Advanced Thyroid Cancer in 2022. And this picture here shows 6 patients who were treated with targeted therapy. And pre-treatment, for example, patient 1 has this is the tumor, very large tumor burden, a very large cancer, and treated with targeted therapy about 3 months after. Where's my mouse? Right. After treatment, 3 months after treatment, this is significantly reduced cancer or tumor burden. Patient 2, again, sizable cancer or tumor. After 5 months, almost nothing. And so these patients, once the tumor has been shrunk so significantly, they can then proceed to have surgery with fewer side effects or adverse reactions. Again, this is a large, what would be deemed an unresectable cancer before treatment, all of this. And after treatment, 3 months after treatment, there's almost, very significantly reduced tumor size. And so surgery can be pursued in this patient now with reduced adverse effects. However, these drugs, they're plagued with side effects, unfortunately, and can cause nausea, diarrhea, weight loss, high blood pressure, skin rashes, liver toxicity, heart failure, abnormal heartbeats, can cause excessive clotting or bleeding. And so quite often, up to 80% of patients, the dose has to be reduced or withheld because of the significant side effects. In about 19% of patients, the drug actually has to be discontinued completely because of adverse side effects. Thankfully, though, death related to the treatment is low, 1 to 2%. It's also quite costly. I researched the cost of lenvatinib, and it's about $17,000 to $18,000 a month. And patients usually require a few months of treatment, so it's quite cost prohibitive. So in summary, thyroid nodules are very common. As I said, they're seen in 70% of the population. However, most are not cancerous. Most are also, the cancers that do arise, though, are well-differentiated thyroid cancers, and therefore have a very good prognosis or survival rate. Ultrasound and FNA biopsy are cost-effective. They're very useful. minimally invasive, and readily available to patients. Genetic testing can be done on biopsies that are indeterminate, or when we're not sure, to see if there are any genetic mutations, which can further assist in our diagnosis. Pregnant patients with differentiated thyroid cancers usually can wait for surgery after delivery unless the neck mass is rapidly increasing in size. Thyroid cancers are rich in druggable targets and due to genetic mutations that are present, and this is showing promising outcomes with targeted therapy. However, more research is being done, and especially if the adverse side effects, patients need to be aware of them. Hopefully over time, these can be dealt with, overcome. Early differentiated thyroid cancer, papillary thyroid cancer being the most common, is compatible to a very long survival, so highly curable. And hence the need for prompt diagnosis. So patients, who have swelling of the neck, have it checked, soon. Don't wait until it starts growing rapidly and changes before we do that. So need for prompt diagnosis and adequate management, which usually involves surgery and radioactive iodine. That's it for me. I hope this has been useful to everyone. I hope people understood. I tried to not use the medical jargons, but I tried to explain as best as I could. Thank you.
Thank you, Dr. Siraj. Thank you very much. I think it was there were some things in there we never heard before, but I think for the most part we could keep up with you. But now is the time that if anyone didn't understand something, they can ask questions. So the floor is open. You can either open your mic and ask your questions directly, or if you type them in the chat, we will read them out for you. So we'll just give a few minutes. If anyone has any questions, feel free to go ahead.
Dr. Siraj, you talk about the thyroid, and you said if persons bringing up blood, or they're swelling or they're hoarse. With your thyroid, some persons have overactive thyroid and underactive thyroid. The overactive, I think, is the one that make you lose weight, and the underactive make you put on weight and your eye bulge. Correct me if I'm wrong.
Yes, I mentioned in the presentation, the overactive thyroid disease. Yes, you lost a lot of weight, you get palpitations because your gland is in overdrive. So you lose weight despite increased appetite, your heart is racing, you get heat intolerance, what have you. Whereas the hypothyroid or underfunction is the opposite. So you put on weight, etc.
Okay, and so if someone who has thyroid issue, say it's overactive, like what would be their symptoms other than they have the usual, losing weight, the eyes bulge a bit too?
Yes, they can
Yeah.
get ptosis. Yeah,
Right.
especially if the patient has Graves' disease. Yes, that could be a feature.
Okay. How would they really know that their thyroid is now going into a cancerous stage?
Well, that's a good question. Most hyperactive thyroid glands or nodules, most don't become cancerous. And it's to the fact that when we do our TSH, and if the TSH is low, which suggests that the gland is overactive, we usually do a scan, an optic scan, to see which nodule is affected, and it's usually a hot nodule, but it's the entire gland. And usually the risk of cancer in a hot nodule is very low, as opposed to a cold nodule, which is a hypothyroid state or underfunctioning state.
Okay, so the opposite would be more susceptible of getting cancer than the other one.
Yes.
Okay, all right. Thank you.
You're welcome.
Sorry, I have a question. I don't know if there is any connection or whatever, but is there any connection to the thyroid with the tonsils? Or, you know, if you have tonsil problems, is there any connection usually?
Usually not. No, there's separate entities.
Oh, okay. There's a question in the chat, I think, 1 second. Somebody's asking, Viola's asking, does everyone with thyroid cancer, I assume, have to do surgery, or can a pill, I guess, is there a treatable form in medication versus surgery?
So according to the American Thyroid Association, the recommendation is surgery, the thyroid gland removal, as well as treatment with radioactive iodine. So that's what's recommended by the association.
Is there any, I guess, somebody who has had their thyroid removed versus us who remain with the thyroid? How has your life changed?
Once these patients who have had the thyroid gland removed, once they continue to maintain their taking the medication, which is the hormone that's given as a pill, Synthroid, once they're compliant with the medication and the levels are monitored and it's working, you know, at the right level, these patients are similar to patients who have a thyroid gland. They function similarly, as opposed to patients who don't take the medication, and they exhibit the effects of an under-functioning gland because you have a low hormone level. And so these patients put on weight, they're lethargic, they're always tired, they lose their hair, the skin is dry. So it's important to
take the medication. Okay, thank you. Any other questions? Okay. Well, I think that might be all the questions, but I would like to thank you, Dr. Siraj, for taking the time to come out and speaking on this topic. Certainly it's the first time we've had a presentation on thyroid cancer awareness, and so I think it's quite timely for us, particularly in that I gather that there's a greater incidence of it occurring. So we definitely need to know what are the things to look out for, who can we reach out to if we see symptoms. So thank you very much for taking your time this evening to be with us and sharing with our group. And we look forward to seeing you another time.
Thank you for having me. Thank you for having the opportunity to share the information with everyone here.
I don't know if you said it earlier, but for the benefit of those who are left, could you let us know where you're located?
So I am at the Princess Margaret Hospital, as well as my private office, which is located at number 5 Rosetta Street, opposite the Insurance Management Building. I'm with Dr. Leon DePuch, the Juno Building. It's not hard to find.
Okay, thank you. I'm sure that'll be helpful for people as well. So once again, thank you very much. And to those on the group, that we hope to see you all again on September 24th when we have Dr. Sinque discussing childhood cancer awareness. And that will be something fairly new for us as well. So thank you very much. Somebody else in the chat saying very informative and educational. Thank you. And an excellent talk. So thank you very much appreciated. And like I said, I'm hoping that it's been beneficial to all who have listened tonight. So that's it for tonight. Thank you all for joining. Thank you so much. Good to have you all back. And we'll see you all who gather again on the 24th of September. Otherwise, we'll see you in October for breast cancer awareness presentations. So thank you all and have a good evening.
Yep, bye. Bye, everyone. Thank you.
Thank you.
Good night. Thank you and good night.
Recording stop.